Dear all, welcome to the 16th edition of TMC Monologue. Today we have another luminary from our college, Dr. Aravinda, a very young and dynamic community medicine associate assistant professor in Tanjore Medical College. And he did his community medicine from AIMS, Bhubaneswar, and he has significantly and meaningfully contributed to school health, non-communicable diseases, and RM and CH. He has been actively involved in biostatistics, training, ethical review, and community-level program implementation. His earlier tenure in Tamil Nadu public health system, ranging from school health medical officer to block medical officer, has given him a deep understanding of ground-level challenges and health system realities. He is a recipient of several awards, including the ICMR Fellowship, UGCJRF, and several Young Scientist and Best Paper Awards. And he continues to contribute to the Hindu and writes quite a lot of commentaries. And he contributes to global collaborations such as Cochrane and the UNICEF Global Health Media Breastfeeding Series. So today it's going to be a very exciting talk, and it is a matter of great concern to all of us. We would all like to know what is the state of the public health of India, what was the past, what is the present, and what is going to be the future. And I think it's appropriate that Dr. Aravinda has been chosen to deliver this lecture, and he has graciously consented and given his time to share his expertise. The floor is yours, Dr. Aravinda. You can go. Go ahead.
Yes, thank you, sir. Thank you for the warm introduction, sir. So, a very good evening to all the participants who have been joined in the Zoom meeting. So, today I will be discussing about public health past, present, and future. So, myself, Dr. Aravinda, I'm an assistant professor. So, today is one of a happy moment for me because though I have not graduated either my UG and PG with Tanjore Medical College, thereby disqualifying me in becoming an alumni of Tanjore Medical College. But I have a very strong and personal association with Tanjore Medical College. So I'm very happy to contribute to this TMC dialogues. So we'll be discussing about public health, past, present, and future. So today I will be discussing, before moving on, I will be explaining what is public health and what are the components of public health and the origins of public health and the difference between the British model and the USA model. Once this has been done, I think it is very easy for me to discuss about the past past of India's public health, the present status of India's public health, and what lies for the future. So before moving on, I just want to drop in a simple question to the audience. When you do a Wikipedia entry for community medicine, it will directly redirect you to public health, and there is no specific Wikipedia entry for community medicine per se. But at the end of the lecture, I will just again allow you a food for thought whether community medicine and public health are one and the same. So now moving on to my presentation. So what is public health? So whether public health is an art or is it a science? So if it is a science that is meticulously grounded in evidence, or is it an art that relies on creativity, human connection to inspire change? And if it is an art, so we can say it is an art because it involves effectively crafting health messages and convincing communities about the importance of, let's say, vaccination program or health, family welfare and family planning, or even a simple thing like promoting hand washing, because these things are core activities of public health, and this requires imaginative storytelling skills, emotional appeal, and persuasive communication skills. And if it is the case, though, then what is the explanation for the following things? Because public health has solid scientific evidence, scientific foundation that is evident from, let's say, germ theory of disease or the modern sewage systems, or even the analytical study of poverty's impact on health, or the demographers doing a census. Now, even if we consider it as a science, what kind of science is it precisely? Whether it is medical science that has strong link to germ theory of disease, or engineering science because the construction of complex sewage systems, or perhaps social science based on because we do study poverty and human behaviors also. So to summarize, actually public health medical science provides knowledge about disease, vaccines, and preventive medicine. And engineering science, as I mentioned, it ensures the infrastructure such as clean water, sanitation, and pollution control, while social science addresses this human behavior. So now, to summarize, public health is harmoniously combining all these various sciences like medicine, engineering, and social sciences through artful communication, thereby advocating social advocacy. So public health is both interdisciplinary and multidisciplinary. It works at the intersection of multiple fields to improve the health and well-being of entire population. Now, whether public health is medicine or it is more than medicine. So public health is not a subdomain of medicine. It is a misconception, and it is a narrow and incomplete view. Public health is both an art and science, and it combines the best of medical science, engineering solutions, and social sciences understanding. Now, coming to the next confused one, whether public health and primary care are synonymous, or whether primary care is a subdomain of public health. Actually, there are a lot of overlapping functions between public health and primary care, but there are significant differences too. So let us see what are the important differences. So when it comes to the level of focus, primary care mostly focuses about the individual patient, whereas public health focuses on community. And primary care, we focus on curative illness, whereas here we focus on prevention, protection, and promotion of health. The typical activities in primary care will include diagnosis, treatment, follow-up, prescription, whereas here it is about vaccination, sanitation, and disease surveillance. The type of health issues covered include minor infections or chronic infections, where we do give follow-up counseling for uncomplicated cases like uncomplicated cases of diabetes, hypertension. Whereas here it will be outbreak control, executing maternal and child health programs, and environmental health. Mostly primary care in all the countries are delivered by general physician, whereas public health, though in some countries it is led by the physician, but it is mostly a team work where public health teams of epidemiologists, entomologists, health administrators do deliver it. And the outcome is mostly relief of symptoms and restoration for individual health, whereas here it is reduction of disease burden in the community or population level. So I have taken this graph from the following study. So as you can see, public health and clinical medicine are two independent domains. At the macro level, we deal about health economics, public health law, trade or public health policies, global or international health, and political economy of health. At the meso level, the health system administration, healthcare financing, and occupational health comes into place. At the micro community level, where you typically see in the primary healthcare centers, we deal about epidemiology, biostatistics, demography, social and behavioral science, public health and nutrition, and public health ethics. Whereas in clinical medicine, it has a very easy classification of primary, secondary, and tertiary care. Now, where does the community medicine specialist stand? Even in India, we community medicine specialists are not properly trained for public health at the macro level, that is state, country, or global level, but we are trained at the meso level, that is organization or district level, to manage it, and micro level, that is managing the block or primary health center and providing a basic clinical services, and MBBS doctor can do it. Whereas a family medicine specialist does not do about the organization or administrative job, but he also does this macro community level up to secondary level. So this is the distinction between public health and clinical medicine. As you can see, there can be a lot of overlap of functions between public health and primary care. Now, what constitutes public health? It constitutes a field of experts from medicine, engineering, social science and statistics, information technology, communication, law, economics, and even politics, delivered by doctors, epidemiologists, environmental scientists, sanitation workers, urban planners. Because if Delhi has been properly planned or Bangalore has been properly planned, we won't be seeing the traffic, noise pollution, or air pollution. Then urban planners, communication experts, data analysts, engineers, paramedics, and climate activists. Now, so the health determinants usually move beyond individual medical care by focusing on preventive health care, environmental sanitation, disease control, health education, and policy making that encompasses community health, occupational safety, behavioral health, and health policy. Now, coming to the origins of public health. As you can see, public health is both ancient and modern. So this is the great Mohenjo-daro bath, and this is the Roman bath. So it is both an ancient as well as modern one. And ancient civilization understood the need for sanitation to prevent diseases. So you can say some aspect of public health was present since antiquity, like the Indus Valley civilization or the Roman civilization. And the modern public health truly began in the late 18th century with industrialization, whereby leading to more number of jobs in the cities, thereby leading to overcrowding, unsanitary conditions, thereby leading to cholera, clostridiums, which are reported widely, leading to the authorities to act upon. And the Britain's landmark Public Health Act 1848 marked the first organized effort to control disease through government policy. And it set the stage for future developments in sanitation and preventive care worldwide. Now, initially, public health revolved around the sanitation, hygiene, and infection control, reflecting the dominant problem during the great sanitary awakening of the 1850s. Over time, this public health has expanded dramatically, encompassing present day food safety, nutrition, occupational health, control of NCDs, sexually transmitted disease, gender equality, poverty alleviation, health disparities, strengthening of the health system, and commercial determinants of health. So, this commercial determinant of health is gaining so much momentum and importance. And if sir allows me for the next cycle, I will be happy to present another lecture wherein these determinants involves the study of aggressive marketing for harmful products which influence health on a population level like tobacco, alcohol, or unhealthy food. So from a simple sanitary ensurement to this level, the public health has traced its evolution in the last 200 years. Now, who delivers public health? Across the globe, the responsibility of public health varies considerably, shaped by historical and administrative structures unique to each country. So, India is influenced by the British colonial past, which I will be discussing in detail in the coming slides. So, the primary function of public health is the responsibility of the state governments, but the central government actively support through funding, planning, and guidelines. Whereas, even though Australia and Canada can be said as former British colonies, yet the public health is at the national level, standardizing health policies across their territories and provinces. And in the United States also, they follow similar to India, where public health is decentralized and managed at the state and local level, with the CDC providing overarching guidelines. But the significant difference is American public health emerged largely from engineering approaches, initially focusing on sanitation and infrastructure. When it comes to Europe, Germany and Switzerland gives autonomy, whereas France and Netherlands have centralized structures, and communist nations like China and Russia have high centralized public health framework with extensive government and surveillance system. Now coming to UK and US model. So before dwelling upon detail into UK and US model, I just want to emphasize that this UK and US model are not competitors or parallels. I can say that this is like Sachin Tendulkar and Virat Kohli. So the American model drew inspiration from British model, and then it developed its own unique thing. But the British model is the one which can be said as the starting point of modern public health one. So it is strongly developed through physician like William Farr, who used mainly for administrative disease control. And here in American one, after they adopted from the British, being a former British colony, they combined the biostatistics and laboratory diagnosis to create a more scientific one. Here in British one, the public health service is predominantly headed by the medical service cadre, that is physician led, whereas here it is a mixed workforce of engineers, chemists, scientists, statisticians, nurses, and city managers. And philosophy here in British one is disease control through clinical administrative governance. Here it is through environmental manipulation, infrastructure, and laboratory science. So it started in 1820s to 1880s. The pillars where the British in their tropical colonies have to face frequent Asiatic cholera epidemics, which resulted in sanitation failure, forced them to create the modern sanitary framework. And John Snow was successful in containing the cholera outbreak without even identifying the Vibrio cholera bacteria or using the microscope, using the modern epidemiological method. And from 1850s, the Paris Sanitary Conference, from where the international health diplomacy started. And it is dominated by medical doctors in Britain, and it is seen as an extension of clinical medicine and centralized and hierarchical. Whereas if you go to American system, which started gaining momentum after the late 1890s, when the germ theory of disease and the discovery of many microbes were done, rapid urbanization and industrialization lead to the historical trigger. Here, the municipality, the engineering departments of municipality took the lead, and it is led by engineers, sanitarians, and bacteriologists. And in USA, it is considered as a separate scientific and technical field, not subordinate to clinical medicine. So it is decentralized, multidisciplinary. The universities based off schools on public health are established in USA. So from 1820s to 60s, the Britain led the global public health effect followed by the Paris Sanitary Conference, wherein the international health diplomacy was propagated. And by 1850s, after the establishment of field of epidemiology, the Britain led till that point. From there, the USA took on the baton, just like Virat Kohli took on the baton from Sachin. And from 1890s, the American model with a predominant focus on engineering aspects started doing this. And by 1915, the Welsh-Ross report, which is formally articulated this American vision. So this is a 300-page report. I have tried to consolidate in a single slide. The conceptual thing is public health should be independent from medicine, not controlled by clinicians. This is American model I am talking about. And the defined schools of public health with core areas of biostatistics, bacteriology, environmental hygiene, epidemiology, and administration. And it is a multidisciplinary workforce with American engineering laboratory model. And this also later influenced the WHO model too. Now, coming to the past of India. So India, this is the Indian subcontinent. The British ruled the present day India, Pakistan, Bangladesh, Bhutan, Nepal, Sri Lanka, all can trace its origin to this British Raj. So I have given the timelines. So I have used the reference of this particular study published in the Indian Journal of Community Medicine. So in the 1764, medical department was created in Bengal. The Calcutta Medical College established in 1835, followed by Madras Medical College and other medical colleges in the provinces. And the Royal Commission on Sanitary State of the Army in India in 1859, after the First War of Independence in 1857, from where the Company Raj to the British Crown was directly ruling. And in 1868, this was the first time they separated the civil medical department from the military medical department. And in 1869, the first public health commissioner and statistical officer was appointed to the government of India, where they will be reporting to the Central Public Health Advisory. And by 1885, the local bodies, where the municipal boards and local boards were made responsible for sanitation. This is the period where Lord Ripon, who is considered as father of local administration in India, was the viceroy for India. And in 1896, the Indian Medical Service cadre was established. Unfortunately, after independence, there was no one to bag for this Indian Medical Service. So this got abolished by the time we got independence. Unlike the Indian Civil Service and Imperial Police, which transformed into Indian Administrative Service and Indian Police Service. And after the First World War, the 1919 Montagu-Chelmsford reforms, wherein the provincial governments established a dual form of government, that is diarchy, one at the center and one at the rural level. A rudimentary form of federalism was introduced, wherein public health, sanitation, vital statistics were transferred to the provisional government. And in the 1935 Government of India Act provided further provincial autonomy, wherein health becomes a state subject, and the Central Advisory Board constituted the All India Trainee. And by 1939, the Madras Public Health Act was the first comprehensive public health legislation in India, for which the modern day Tamil Nadu and Andhra Pradesh can be so proud of. So far, we have discussed about how public health was administered in British India. Now, we will see how sanitation, vaccination, vital statistics were done. So when Edward Jenner did in late 1790s, within the next couple of years, in Mumbai, the Superintendent General of Vaccination was appointed, and formal beginning of organized smallpox vaccination was done. And the sanitary commissioners were appointed in 1864, and the Birth and Death Registration Act, the first time was formed in 1873, and the recent one was done in 1969 after independence. So in the 1880, compulsory vaccination was introduced progressively in municipalities, and this act was one of the reasons why we see vaccine hesitancy, why we can attribute one of the reasons as vaccine hesitancy, because there was compulsory vaccination, and the British Raj see Indians as subjects, not as mere persons. So they didn't bother to persuade, they didn't bother to imaginative storytelling and convince the local population. Rather, they mandated it. And by 1881, the first census was taken, and in the 1880s, sanitary engineers focusing on water supply, drainage, and sewage were appointed. And by the early 1900s, vaccination program expanded. And now coming to how disease control, research, and training were happening in the British Raj. So the British people coming from the temperate zone, they have to invent a specialty called a tropical medicine, where they have to deal with the dreadful diseases like cholera, plague, malaria, leprosy. So they had their contribution in research as well as control from the 1800s to 1900s. And the last Epidemic Diseases Act enacted in 1897 was so old and still relevant because when Modi ji announced that lockdown, the powers, the Epidemic Diseases Prevention Act was invoked to ensure and enforce lockdown was done. So such was the legacy of British Raj. Now, in 1897, Ronald Rose discovered the transmission of malaria, completed the discovery of transmission of malaria cycle. After 5 years, he got Nobel Prize for that. And in 1909, within a couple of years, Central Malaria Board was established. And in 1911, the precursor of Indian Council of Medical Research, that is the Indian Research Fund Association, was established. And the National Institute of Nutrition, which is presently in Hyderabad, the precursor of it, the National Research Laboratory, was established in 1918, and this was the first time Indians got a recommended dietary allowance and what are the local foods that are eaten by the different sets of population was done in 1918. So this is the model that India inherited by the time of independence. So coming to the present model, it is deeply influenced by the British system, and most of the public health activities are managed by the state governments, where they perform the immunization program, vector control activities, entomological surveillance, MCH service, and health education campaigns. And the local body manages sanitation, waste disposal, street cleaning, sewage management, whereas the engineering departments like TWAD board in Tamil Nadu and other similar boards manage the water boards and other engineering related stuffs. So this created silos within silos. So this is the problem that the present day public health in India faces. So even within states, the public health responsibilities remain split. So public health was never housed within a single clear executive arm. The functions of public health were divided between Ministry of Health, Ministry of Water Resources, Food Safety Departments, which falls under Ministry of Consumer Affairs, and local bodies. The scatter also poses a very deep issue. And because of this, we are not able to position public health as a single national cohesive agenda, and this disjointness has a consequences. So now I will because of which public health, most of which is becoming a reactive rather than anticipating and prevention. I will give a small example. We have two research organizations in India, one which fights tobacco and the other one which promotes tobacco. So it will be very surprising, but I will just explain the detail. So Indian Council of Medical Research combats a disease against tobacco. Yet Indian Council of Agricultural Research has a central tobacco research institute in Rajamundry, whose main mandate is to promote the tobacco crops production as well as yield and to make sure that the tobacco farmers are profited. So because of this contraindication in vision, we see in India on public health, one hand tries to heal, the other hand tries to harm. So this problem results in poor response of public health. So this is the Indian Council of Medical Research Central Tobacco Research Institute situated in Rajamundry, Andhra Pradesh, and this is ICMR trying to fight against tobacco. And as you can see, the mandate of this is improvement in quality, value-added products, and also development of tobacco for domestic and exportable types. And this is the first of its kind of Asia. So this is what this ICAR Institute is doing. And recently, the name has been changed to National Institute of Research on Commercial Agriculture, wherein in addition to tobacco, they have decided to do turmeric, chili, castor, and ashwagandha also in research. So it took us almost 75 years to realize that in addition to tobacco, we have to improvise other crops also. The another important problem with regard to public health is its education itself, because the fragmentation lies in this one also. So the design and delivery of curriculum. So MPH curriculum in India mirror the same fragmentation of public health governance, that is scattered, uncoordinated, and lacking national standards. So the eligibility criteria varies. Some universities admit only MBBS doctors for pursuing MPH courses, whereas some universities admit any bachelor's degree without any common foundational baseline. And the course content is also very inconsistent. Some emphasize too much on theory, others too much on management and administrative prospects. Only very few offer technical depth or hands-on training. So, for example, when it comes to public health, we need core areas of public health design, public health engineering, like how to know about water systems, waste management and drainage, nutrition and food safety, like food handling, food technology and FSSI linked skills, and behavioral sciences like behavioral change, social psychology, and social marketing. These are all hardly dealt with. And this 2-year program is overloaded with epidemiology, policy, health economics, behavioral science, and research, leading to superficial learning and inadequate mastery of these three things. And India lacks a dedicated public health cadre, unlike an IAS or IPS. And these MPH graduates often end up in short-term projects or data entry roles in various ICMR projects, undermining the very purpose of their degree. And without technically strong public health workforce, India remains still vulnerable to antimicrobial resistance, climate-linked diseases, and future pandemics. That is why a national coordinated standardized MPH curriculum is required for epidemiology, surveillance, health technology assessment, environmental and occupational health, and policy analysis. And now, because of this scattered system, the public health is often reduced to a state subject in policy circles. But when you look at this thing, this does not reflect poorly. And in the constitution also, this is scattered. So who holds public health responsibility for public health in India? So this is $1 million question. When you look at the World Health Organization definition for public health, it says that public health aims to provide maximum benefit for larger number of people. So if you take this definition seriously, and then look at the Indian Constitution, you will find in the state list under Schedule 7 of the Constitution, entry number 6 will be public health. But if you look at a deeper look at the Constitution, you will find the definitions of public health will be scattered across union, state, and concurrent list, and public health is not exclusively a state subject. For example, take up union list in the Constitution under 7th schedule. Entry number 47 is insurance, which deals with health insurance. Entry number 50, establishment of standards of weight and measure. Entry number 55, regulation of labor and safety in mines and oil fields. Entry number 59, cultivation, manufacture, and sale for export of opium. Entry number 64, establishment of institute of national importance like AIMS, ICMR. Entry number 69, census. Entry number 81, interstate migration and interstate quarantine. Entry number 84, duties of excise and tobacco, though there is some modification post GST implementation. So these are all also very relevant for public health. We cannot say simply that these can be excluded from the purview of public health. Now coming to the state list. Though entry number 6 explicitly mentions public health, if you look at entry number 4, the prisons, reformatories, and bar stalls, they play an important role. Entry number 8, intoxicating liquors. Entry number 9, relief for the disabled and unemployable. Entry number 10, burial and cremation grounds. Entry number 14, agriculture, education, and research and protection against pest. This is very significant because it focuses about nutrition, pesticide exposure, zoonosis, and food safety. And more importantly, in the last 50 years, 70% of all the emerging and re-emerging diseases have zoonotic origin, including the recent COVID-19 pandemic. And in all likelihood, all the future pandemics will likely have a zoonotic origin. So this is quite important. And entry number 17, water supply, irrigation, canals, and drainage. Entry number 18, ponds and prevention of cattle trespass. Entry number 34, betting and gambling, where mental health is also a predominant part of public health. And excise on alcoholic liquors, opium, and narcotic drugs. Entry number 51. Now coming to concurrent list, where both the central government and the state government can manage. So entry number 5, marriage, divorce, minors, and adoption. So since demography is also a part of public health, we have to consider this also. Entry number 16, lunacy and mental deficiency. Entry number 17, prevention of cruelty, forest protection of wild animals and birds, since One Health, zoonotic spillover, climate-linked disease pattern, environmental health. All these aspects are under concurrent list, which is also a core function of public health. Then another important one, adulteration of foodstuffs and other goods, food safety, nutrition, and toxicity prevention. This also is a part of public health, but it is placed under the concurrent list. Entry number 19, drugs and poisons. We recently saw in Madhya Pradesh how innocent children has to die because there is a poor regulation on this part. Entry number 20, economic and social planning. Entry number 20A, population control and family planning. 23, social security and social influence. 24, welfare of labor. And most importantly, the current one that we are discussing, entry number 25, medical education. These all belong to the concurrent list, including entry number 30, vital statistics, which also deals with citizenship in addition to birth and death registration, mortality surveillance, and epidemiology. So when I have just summarized in this side, I'm not going to explain this in detail. So when you see this, public health functions are constitutionally distributed among union list, state list, and concurrent list. So present day in India, we don't have a nationally cohesive agenda. We don't know who is the authority and what is the problem with public health problem. And most of the problems that we tend, most of the things that we tend to do are mostly reactive in nature rather than anticipating and preventing and promoting public health, leading to increased life expectancy with lesser morbidity and mortality. Though we are quite successful in reducing the mortality, but we are not very successful in reducing the morbidity and the quality of life. When you include DALI and HALI, it has been not very happy numbers, and the numbers are very rockingly high, including the out of bucket expenditure. So this results in a fragmented public health governance between different layers of the government without coherent chain of command or common vision. And this is not accidental, but a colonial inheritance. So India maladopted much of its health structure from the British system, which is a unitary state. In Britain, we don't have states like Tamil Nadu, Kerala, Karnataka. That is a unitary state. While we are forming a federal state with three-tier nation, yet we, instead of following a US model, we followed the British model with a physician-centric focus. So what is the way forward? What are the future problems that I tend to see for public health in India? So in the coming decades, I believe that public health and global health will merge, and health threats will be increasingly transnational and borderless. Traditional and tech-driven risk will coexist, meaning the previously emerging diseases and new diseases like Nipah virus or Congo hemorrhagic fever or Marburg virus will be there, and tech-driven risk like internet addiction or porn addiction, both will coexist. And a shift, there has to be a shift from reactive to anticipatory system, and the digital and internet addiction will intensify. And there will be new biosecurity and pathogen risk, because this large language models are known to create new pathogens if it lies into the hands of non-state actors or terrorist groups. Then genomic revelation can bring down the cost and also drive precision in first public health. But we need to focus about the antimicrobial crisis threatening the modern medical advances. Then migration and urbanization, accelerating the disease spread. This also has to be could be a future problem. And cross-cultural misinformation underlining public health programs. So this infodemics, this WhatsApp forwards, and many conspiracy theories being propagated through various social medias like Facebook or YouTube. This also is going to be a bigger headache and problem. And with the rise of technologies like deep fakes, there will be a very thin line between what is truth and what is unreal, even to the experts. So these are all the problems that I envision, along with the global mental health burden rising sharply. So what could be the solution? So back in 2017, when the government of India announced its national health policy, they promised to create a unified public health cadre by the year 2022. So even after 3 years, we are yet to see any unified public health cadre. And there has to be a shift in focus from mortality to morbidity reduction too. And we have to build an interdisciplinary cross-sectoral health workforce and strengthen the clinical and public health collaboration, and expand digital health analytics and surveillance, and enhance the global diplomacy and cooperation. And last but not the least, unless we make today, tertiary care is a very profitable business. That is why we tend to see a chain of corporate hospitals like Apollo, Malar Fortis, or any other group of hospitals that we tend to see. But we do not see a chain of sub centers or a chain of primary health centers, because primary care or public health, they are not profitable. So we have to invent a new revenue model that make this public health sustainable, profitable, and more importantly, professionally rewarding for not just doctors, but all the public health experts who are involved in public health. So to conclude, public health means national building. And I want to end my presentation with the famous quote my professors used to say to me during my post-graduation. Whenever we ask, so during our post-graduation days, there has to be an internal assessment for every 6 months. So whenever we ask them what is the syllabus for this internal assessment, they used to say, everything under the sun is public health. So I just wanted to end the quote with everything under the sun is public health. And I started with the question whether community medicine is equal to public health. So I leave it to you with an open-ended question, which you can fill up in the chat box. So what do you think, whether community medicine is equal to public health, or we have to increase the standards of public health in India? So with this, I conclude my presentation. And I wanted to acknowledge Dr. Swaminathan sir for adding me in the TMC case conference group. and Dr. Venkatesh Natarajan sir for offering me the opportunity to give a talk in this lecture series. And last but not the least, I wanted to thank and dedicate this to my teachers at AIMS Bhubaneswar.